Now it is working. So, yeah, is it? So good afternoon, everybody. So I see that everybody is very enthusiastic in presenting. So we'll start as the time is also now on. So we'll start with the first topic, the silent assassin, endogenous fungal endophthalmitis in COVID-19 era, a case series by Dr. Subhojit Chakravarti. Let me just see if everybody's there. Dr. Jonathan, yes. Dr. Manisha, yes. No, that is Dr. Manisha Karti. Dr. Seronegative rheumatoid, she's not there. Dr. Bhuvneshwaram is there. Dr. Aditya Patil is there. Dr. Abuli N. Dr. Obuli N, not there. Dr. Ditsha, not there. Dr. Nida Khan, there. Dr. Aditi Joshi, no. Dr. Aditi Joshi. So, Dr. Shivagami, there, yes. Dr. Ashish Markan, not there. So we have only 1, 2, 3, 4, 5, 6, 7 people there. So the competition is much more decreased. So all the very best to you. So
time for the judges to ask questions goes up. Presentation
so
stays for 5 minutes only.
So for more questions would be asked. So all right, so we can start. Dr. Subhajit, please start.
Screen has. Ma'am, the screen is blank. Ma'am, screen here is blank. Screen blank.
His screen is blank there.
Please timer पर से on कर देना.
Shubhojit, relax. Timer is for 4 minutes or 5 minutes? 5 minutes.
Good afternoon, respected judges. The topic for my presentation is the silent assassin, the endogenous fungus endophthalmitis in the COVID-19 era, and I give a few case series. Now, what is endogenous endophthalmitis? It occurs due to generalized infection or hematogenous seeding of fungal pathogens. It constitutes 35 to 65% of all cases. Now, the COVID-19 pandemic led to widespread use of systemic steroids along with the various ocular associations. And it is due to the direct result or the cytopathological effects, the adverse effects of pharmacologic therapy. It may be due to prolonged hospitalization or alterations in the host immune response. Now, our first case was a 61-year-old lady who complained of dimness of vision and was on systemic steroids. In imaging, we obtained the double target sign, which was characteristic of liver abscess, and choroidal abscess was found infratemporal to the macula. Our second case, we got string of pearls appearance. In our third case, we got a 64-year-old male complaining of floaters, and no fungal biopsy was not confirmatory, and it was a presumed case of endogenous fungus endophthalmitis and was responsive to oral ketoconazole, itraconazole. In our next case, which was also a case of RT-PCR confirmed COVID-19, we've got systemic evaluation revealed right hydronephrosis, and vitreous tap was positive for septate hyphae of Aspergillus fumigatus, as shown here. Now, our next case, we could not see anything. There was dense vitritis and a yellow-white lesion about half disc diameter inferiorly. We proceeded for pars plana vitrectomy and got Cryptococcus neoformans. In our next case, we got a well-defined oval yellow-white lesion in the left eye of macula. Here also, we opted for pars plana vitrectomy, and fungal culture confirmed Candida albicans. In our next case was a 50-year-old female who was complaining of pulmonary hypertension developed after hospital stay, and HRCT thorax was suggestive of fungal infection, which was confirmed on bronchoalveolar lavage fluid. In our next case, we also obtained mild vitritis with fluffy snowballs. Vitreous tap was negative. Our next case was almost the similar finding with vitreous microscopy showing aspergillosis flavus on Sabarus dextrose agar culture. And final case was a yellowish pre-retinal lesion suggestive of infectious fungal keratitis. Now, this was the detailed data of our patients starting from duration to presentation. Now, coming to the discussion part, identification of systemic focus is of prior importance in these cases, with many new recent inventions coming to the fore. Higher preponderance of male patients was seen in our study, with our mean age presentation being 57.4 years. Diabetic-related systemic complications was the most common background. In our study, lungs was the most common primary site of infection, and all our cases had RT-PCR confirmed COVID-19. Now, there is a low yield in vitreous tap and culture, and so they need to have a high index of clinical suspicion in at-risk patients with prompt initiation of medical or surgical therapy, which may improve the clinical outcome. It depends on the various factors being causative organism, the severity of involvement of the ocular chambers, and follow-up. Now, I would like to conclude by saying that though a rare presentation, it can have a devastating effect of vision, particularly because the presentation is silent. Now, thank you everybody. Welcome.
Dr. Subhajit, you had 10 cases
Yes,
of
ma'am.
fungal
Yes, ma'am. Yes.
So could you compute what is the risk factors in these patients?
Ma'am, the risk.
Diabetes is there for now.
Yes, ma'am.
COVID.
During the COVID-19 era, there was a huge rate of steroid use, systemic steroid use, particularly.
These 10 patients.
Yes, ma'am. In these patients, there was, in 40% of cases, we had a history of indwelling catheters. After admission, catheter use.
Actually list the risk factors which these patients had.
Yes, ma'am, because shortage of. Yes.
All right, thank you.
Welcome.
So I think one presenter has asked for an earlier presentation. Yes. Dr. Ashish Markan. He will be presenting on quantitative assessment of peripheral choroidal vasculature in ultrawide field
2975.
in posterior uveitis.
A very good afternoon to all. So I'll be talking about the quantitative assessment of peripheral choroidal vasculature on ultra-wide field ICG in posterior uveitis using advanced image processing techniques. So just to introduce, we know that with the emergence of ultra-wide field ICG, it has broadened our analytical scope to assess the choroidal vasculature, especially to look at vortex vein ampullas, the choroidal drainage and the outflow, and the morphology and dimensions of the vortex vein in various eye diseases. So this has been studied in diseases like polypoidal choroidal vasculopathy, central serous chorioretinopathy, but there is currently a lack of data on quantification of these choroidal vascular parameters in posterior uveitis. So the present study aims to bridge this gap by quantifying various parameters using ultra-wide field ICG in eyes affected by posterior uveitis. So it was a retrospective study. All these patients, they underwent FFA and ICG, and images from the intermediate phase were taken for image analysis. Only well-centered images with visualization of minimum of 3 vortex vein ampullas were included, and a Python program was used to analyze the images and to calculate the various choroidal vascular parameters. The exclusion criteria included the poor fixation, media opacities, other ocular comorbidities, and poor quality images. So what all parameters did we study? First was the asymmetry of the choroidal outflow. Second was the choroidal vessel densitometry. Third was the ampulla distance from the optic nerve. And fourth was the diameter of the prominent choroidal vessels. So to begin with, we need to do image registration. For this, FFA and ICG images were overlapped on each other, and a rotational, scaling, and translational artifacts were removed. So we received a registered image, which is the subtracted image from which the retinal vessels have been subtracted from the choroidal vessels. Now the next thing is that you apply thresholding. Thresholding basically binarizes the image. We can either apply adaptive thresholding or a global thresholding to receive a final image which is used for analysis. So firstly, the asymmetry of the choroidal outflow. It was studied in terms of the brightness of the pixel intensity on each of the quadrants. So this is how a Python program looks like. So first of all, this is the interface for the Python program. So you select the registered image, you upload it on the Python program, and then you click on this on run all. So run all has all the mathematical formulas, and it will cause the thresholding and binarization of the image. Once that is done, so it will automatically calculate the pixel intensity in each of these quadrants. So you can see the quadrants have been divided into 4 equal parts, and finally we get the brightness of each of the quadrant. So the difference of the maximum brightness minus the minimum brightness will be the asymmetry of the choroidal outflow from that eye. Second parameter was the choroidal vessel densitometry. Again, the registered image was being uploaded onto the Python program. In this case, adaptive thresholding was applied. And you click on run all, and then you select the region of interest where you want to calculate the choroidal vessel densitometry. And the mathematical formulas, they were calculated, and it calculated all the non-zero pixels or the white pixels. So the ratio of the white pixels divided by the total number of the pixels gave the choroidal vessel densitometry of that particular eye. Third was the ampulla distance on the optic nerve. This was quite straightforward. You upload the image, then you basically select the, the coordinates. So you click on the optic nerve, you'll get few coordinates. You put it into the formula. Similarly, you go and click on various ampullas, and you'll get few coordinates. So once you receive these coordinates, so you put them into the formula, and the formula basically uses the Euclidean distance mathematical formula, and it will give the distance. It will convert the pixels into millimeters, and you'll be able to calculate the ampulla distance from the optic nerve till the vortex vein ampullas in each of the quadrant. And the final was the diameter of the prominent choroidal vessels. Similarly, again, the image is registered onto the Python program. You divide the image into 4 equal quadrants, and then what we do is, this is how the resultant image is. So it has been divided into 4 quadrants. The program will itself mark all the prominent choroidal vessels. If you feel some of the vessels have been missed, you can manually mark them. The different colors actually shows that various vessels have been marked, but all of the prominent vessels have been marked. And then the formula will automatically calculate the mean value of this quadrant. So you'll be able to calculate the mean values of each of the quadrants. So coming on to the results. So a total of 31 cases and 14 controls were included, and we had entire spectrum of posterior uveitis in the cases. The mean average asymmetry of the choroidal vessels was 14.89 pixel units. Choroidal vessel density in the cases was 0.36. So this is the ratio, so it will come in 0.36. And the distance was 10.83 to 11.45. Coming on to the diameter of the prominent choroidal vessels, it was comparable, and it ranged from 0.37 to 0.4 millimeters. So this is the first study which has actually looked at the diameter of the prominent choroidal vessels. There is no other study till now which has calculated the diameter of the prominent choroidal vessels. Now coming on to the control versus cases. So what we found was the choroidal vessel density was significantly lower in the cases. Similarly, the diameter of the prominent choroidal vessels was significantly more in the inferior quadrant in the cases as compared to the control group. So this could be because of the long-standing persistent inflammation and causing some secondary changes in the choroidal stroma and the choroidal vasculature, which could have led to low CVD. So just to conclude, our study showed that the CVD was markedly decreased, and diameter of the prominent choroidal vessels in the inferior quadrant was significantly increased in posterior uveitis as compared to the control group. And this is important because quantification and analysis of such parameters can assist clinicians and researchers in better understanding the intricate changes which happen in the ocular vascular anatomy, particularly in pathologies like posterior uveitis, and provide an objective tool for monitoring and response to therapy. Thank you.
Good. New technologies, Dr. Ashish. But as you said that it was multiple, like the cases which you took were of all types of choroiditis.
Yeah.
So like, if you say quadrant tick, so where were the choroidal tubercles or choroiditis patches? So that would affect the various quadrants.
That is what the beauty of Python programming is, and all these algorithms which we have used, it has automatically subtracted them. But you're right, because we have included all these patients, so there is always some variability and there is some bias which happens. So the next project is that we are trying to study only one particular subset of uveitis, because we were actually designing this software. Yeah. So that is why we tried to include all the eyes.
It could be a pilot study.
Yeah.
So because you have to study more, because you have to study where the choroiditis is, and then is that quadrant involved or not?
That is what happened, because in patients of serpiginous like choroiditis, where there were too extensive patches, we have excluded those patients, yes, which were actually...
Otherwise, I think it's a good beginning.
Thank you.
All right. Thank you. We call our next speaker.
So this Dr. Jonathan is here, right? So we next call upon Dr. Jonathan Chavan. His topic is double trouble endogenous endophthalmitis in a chronic one-eyed VKH patient.
Good afternoon, everyone. I'll be presenting on a rare case of endogenous endophthalmitis in a chronic one-eyed VKH patient. So both VKH and endogenous endophthalmitis can cause dreaded ophthalmic complications. VKH needs to be treated with aggressive immunosuppression, and endogenous endophthalmitis needs prompt treatment with systemic antibiotics and to do a co-vitrectomy. So 10 years ago, a 47-year-old female first presented to our clinic with right eye decreased vision since 4 years and left eye decreased vision since 2 months. In both eyes, there was associated intermittent redness. Positive history was she gave history of hearing loss, and negative history, there was no ocular trauma. We did a B scan which showed thickening of the RCS complex. So our initial diagnosis was right eye prethysis bulbi and left eye was VKH. We started topical and oral steroids, and because VKH is an absolute indication for immunosuppressants, we started methotrexate. Following treatment, her vision improved from 636 to 6/6. Inflammation was well controlled, and after cataract surgery, her vision also was 6/6. Due to multiple recurrent episodes with methotrexate, we decided to switch to MMF, and for almost 10 years she had inactive uveitis. Then suddenly she presented to us with a drop in vision from 6/6 to 5/60. On ocular examination, there was active inflammation with 2+ cells and flare, and on fundus examination there were 3+ cells with a vitreous haze of 3+. When we did the B scan this time, there were dot echoes present with a normal RCS complex and no evidence of retinal or choroidal detachment. So we were wondering what this could be. Could it be VKH or is it something else now? So we suspected endogenous endophthalmitis because of the sudden dense vitritis. We did a urine culture which was positive for Streptococcus viridans, and ultrasound abdomen was suggestive of pyelonephritis. So we immediately stopped immunosuppressants. We started topical antibiotics. With the help of a urologist, we started oral antibiotics. Then we did a co-vitrectomy and injected intravitreal vancomycin, ceftazidime and voriconazole. Following treatment, her vision improved to 6/6. So we both know that endogenous endophthalmitis and VKH can cause a poor visual prognosis. Unfortunately, the immunosuppressants used for VKH can predispose to endogenous endophthalmitis. So the clue to endogenous endophthalmitis in our case was the sudden onset of severe vitritis, which we do not usually see in chronic recurrent VKH. So therefore, with this alertness, we were able to save the only seeing eye of a one-eyed patient and helped her regain 6/6. So we like to conclude that it's always important to pay attention to even the most subtle changes in clinical findings in every case of uveitis that comes to our clinic. Thank you.
Especially if they are on immunosuppressants
Yes,
for a
ma'am.
long term. All right.
It's a very nice presentation. I'm wondering why this entire thing happened. See, the patient has to be reasonably immunosuppressed
Yes, sir.
for him to get infection at 3 different sites.
Yes.
I would be really interested in knowing what the total leukocyte count is like. Was the patient into something like a bone marrow suppression or you know?
No, sir. She used to come for a regular follow-up with us, sir. Every 2 to 3 months, she comes for checkup. Her leukocyte
And,
count was
and
normal.
then you're really scaring me if you're saying
Yes,
that.
sir. Yes, sir.
Okay.
So what you're saying is you couldn't pick up the TLC drop, the bone marrow suppression earlier.
Yes, sir, ma'am.
Right. Okay. Thank you.
Okay.
So we call upon our next speaker, Dr. Manisha Agarwal. She'll be talking on comparing combination therapy versus systemic therapy for managing ocular tubercular granulomas.
A very good afternoon to all of you. One three eight. A very good afternoon to all of you. So tubercular granulomas is the most well-recognized phenotype of intraocular tuberculosis. These are hypoxic granulomas with very high VEGF levels, leading to abnormal vasculature around these granulomas, and leading to an unequal distribution of the ATT drugs, thereby reducing it to a monotherapy and causing the risk of multi-drug resistant TB. The hypoxia also makes the MTB bacilli dormant, and INH in the ATT is unable to act on the dormant bacilli. We have published our initial work where we found that the VEGF-A levels in these granulomas was 5 times higher than that found in a CNVM, and a prompt clinical regression was found in all the cases on giving treatment with anti-VEGF along with moxifloxacin. And this is the role where we give anti-VEGF, which decreases hypoxia. It avoids the bacilli from becoming dormant, because of which the INH becomes more active, and it also normalizes the vasculature, thereby decreasing the risk of multi-drug resistant TB. However, the limitations of our previous study was that it was a non-randomized study, and the sample size was small as 10 patients, and there were certain questions which remain unanswered. How do these granulomas behave on a long-term basis? What are the recurrences? And how does the healing differ when we treat them only with the systemic therapy versus a combination therapy? So the aim and objective of this study was to compare the anatomical and visual outcomes between intervention group, which was the combination plus systemic therapy, versus the control group where only the systemic therapy was used, and also to compare the recurrences between the two groups. It was a randomized prospective study, and all the consecutive patients of intraocular TB granulomas from January 22 to September 23 were enrolled in this study. The intervention group included an intravitreal injection of bevacizumab along with moxifloxacin, which was given every week till the granuloma regressed, along with the systemic therapy. And we also analyzed the aqueous samples for the VEGF levels. This is one of the case examples from this study, which is a 16-year-old young female patient who had bilateral TB granulomas, and you see a large granuloma in the right eye, which was enrolled in the intervention group, and the left eye was put only on the systemic therapy. This is the timeline of the right eye, which was treated with 4 intravitreal injections of moxifloxacin along with Avastin, and you see the high VEGF levels which were touching 2000 picograms per ml. There was a beautiful regression of the granuloma in the right eye, and the patient recovered a vision of 618 N8 after 4 injections along with systemic ATT and steroids. In comparison, the left eye, you see that there is a regression of the granuloma even in the left eye without the intravitreal injections, but the difference, if you notice, is very subtle. You have extensive RPE atrophy, which you can well appreciate in the macular area, and the scarring of the granuloma is very high in comparison to the other intervention group. We did face recurrences in the right eye, and where you see there are 3 recurrences which were seen at 12 weeks, 36 weeks, and 68 weeks. But they were all the reactivation of the CNVM, which we picked up on OCTA, and not the reactivation of the granuloma. So we had 26 eyes of 23 patients. The mean age was around 25. 24 eyes had choroidal granulomas. 2 eyes had optic nerve head granuloma. 7 patients out of 23 had an evidence of active systemic TB, and 3 patients had a history of ATT in the past. There were decreasing levels of VEGF levels, which correlated well with the clinical regression of the TB granulomas. The minimum follow-up was around 24 weeks, and the average size of the granuloma was 4 disc diameter. However, the recurrence rate was quite comparable in both the groups. And if I was to highlight the difference between the two groups, the time of regression of the granuloma was around 4 weeks in the combination versus 11 weeks in the control group. The healing showed less scarring in the combination group versus more scarring in the control group. The visual outcomes were better in combination because of more scarring. The vision either decreased or stabilized. The recurrences were comparable in both the groups, and the flattening of the granuloma took more than a year in both the groups, and it was really not dependable on what therapy we used. So to conclude, a combination of intravitreal injections, that is anti-VEGF, moxifloxacin, and systemic therapy, offers an advantage over systemic therapy of ATT and steroids alone in both anatomical and visual outcomes. The recurrence of fluid is primarily because of the reactivation of the RAP or the CNVM lesions and not the granuloma. The number of recurrences are very much comparable between the two groups. Thank you so much for your patient listening.
I think it's That's a very good initiative which you have taken. Just one or two questions. You have put intravitreal moxifloxacin also, which also has a ATT effect.
Absolutely.
So you think it was the anti-VEGF or the moxifloxacin which did the trick?
So, ma'am, in our first paper that we have published, we have described that both anti-VEGF and moxifloxacin have their own different roles to play. The anti-VEGF basically acts on the abnormal vasculature that's developing around the granuloma, so that the penetration of the ATT drugs is much more to the center of the granuloma. As far as the moxifloxacin is concerned, it is acting on the macrophages which are surrounding the granuloma, which are harboring the MTB bacilli. So it is basically going to be pushing out the MTB bacilli and killing them.
So you think if only moxifloxacin is given,
It
will
won't
also-
act. It won't act. It won't.
Are there any studies on that?
Yes, there are studies, and the reason being because macrophages are in turn surrounded by the abnormal vasculature. So till you don't get rid of that abnormal vasculature, the drug is not going to be reaching the macrophages.
One more question. Your diagnosis of tuberculous granuloma, like you said, only 7 patients had active tuberculosis.
Systemic TB.
Systemic TB.
Yes.
So did you do a PCR for the AC tab to confirm?
Very few patients. I think out of the
How did you make a diagnosis of tuberculosis?
ma'am, we have like it is.
Clinical.
It's a
Clinical.
the phenotype is so typical of a TB
So
granuloma.
clinical, it was a clinical.
Yes, it was a
diagnosis.
clinical.
Right.
Just one question. I wanted to know, you are giving these injections every week.
Yes.
Every week? Or
Yes.
Yeah.
Every week.
So,
So-
what would happen if I spaced them a bit more? And
So, in our initial experience, when we used to treat them like once a month, it used to be a very slow
Yeah.
response. And we lost those eyes. They became painful blind eyes with extensive neovascularization of the iris. Now, because we've done a VEGF analysis and we know what high levels of VEGF we are dealing with, and also because these are inflamed eyes, you have a breakdown of the blood retinal barrier, so the washout of the drug is much faster. So once a month is too low a dose. And now from the time we have started treating them once a week, the granulomas regress beautifully, and we have never had a complication that the eye have become an absolute eye.
so it's between once a month and once a week.
Yes,
It's-
absolutely.
So you've just taken it as once a week. And another question is, would you think any other anti-VEGF?
Absolutely. I mean, you can use any.
I'm just saying that from the point of view, you could use anyone, but then would it reduce the time that is required? Because you are also a retina specialist. If
I
you
would
if you
totally agree
use-
with that, Dr. Mayur. That's a very keen observation. Since these patients were non-affording and Avastin, we
Yeah.
can give free, so we opted for Avastin. I'm sure other anti-VEGFs will also have a role to play. And if you have a longer durability of the anti-VEGF, probably yes, it can increase the increase the frequency or decrease the frequency of the injections. But I'm not too sure with the high load, like I showed, it's 2000 versus a CNVM which has only 250 picograms per ml of VEGF, whether that's really going to be able to compensate.
Having said that, if you went that way, you would lose the advantage of having the weekly moxifloxacin.
Absolutely. I agree.
And
I
also the VEGF you calculated was the serum in the
No, ma'am, it
plasma?
was from the AC tap.
So you did AC tap every 2-3 times to see how much the
Not
VEGF was?
really. Otherwise, whenever we gave the intravitreal injection, we took an AC tap sample and then subjected it to an ELISA to get the VEGF
So you
levels.
have the ELISA in your
Yes, we do
institution
have.
for
Yes.
VEGF.
Yes.
Thank you.
Thank you so much.
So is Dr. Yeah. So Dr. Bhuvneshwaran, his topic is levofloxacin as a replacement to ethambutol in anti-TB regimen for ocular tuberculosis.
Good afternoon and all. I'll be talking on the topic levofloxacin as a replacement for ethambutol in ATT regimen in ocular tuberculosis. I don't have any financial interest. So, and ATT, it started with the discovery of streptomycin, and since then newer antibiotics have been developed. People have been trying to cure TB in whatever known ways possible. Even the current standard the TB regimen which has been suggested by the WHO faces one problem which has been consistent throughout, which is the patient compliance. So that is why they recommend direct supervised medications to the patient. So this is in Indian scenario. We have Intraocular TB is classified under extrapulmonary TB, and we treat it with 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, followed by 7 months of maintenance phase, which is rifampicin and isoniazid alone. In our study, we propose the efficiency of levofloxacin as a instead of ethambutol. So it's an observational study on 23 patients for whom levofloxacin was prescribed instead of ethambutol. So what is the difference between these two drugs? One is ethambutol is obviously a first line drug, but whereas levofloxacin is obviously a second line drug. But ethambutol, it is a tuberculostatic drug, whereas levofloxacin is a bactericidal drug. The side effect of ethambutol, why we are trying to avoid ethambutol, is primarily the patient has come for a visual complaint, and the risk of patient having color vision loss or field defect, developing optic neuritis is a bit more than it is because of ethambutol we see in patients treated with ATT. Whereas these side effects are not there in levofloxacin, whereas are pretty less in levofloxacin. Whereas in ethambutol, the advantage is it prevents resistance and sputum conversion. In our patients, we had a data of 23 patients, predominantly male. Average age was 30. Majority of our patients were bilateral patients, and these are the uveitis conditions in whom TB was found, and TB was found based on these investigations according to the standard flow chart. And we had given the patients, the treatment was started by a pulmonologist, and it was based on the age and weight of the patient. The patient also received oral steroids and MMF or azoran from ophthalmologic point of view for the control of inflammation. When I submitted this thing, we had a follow-up period of 3 to 17 months period in these 23 patients. None of the patients had a reactivation of uveitis during the follow-up. So even globally, there are people are trying newer regimens for TB for better patient compliance. So in our I conclude that levofloxacin is a viable alternative to ethambutol in treatment of ocular TB. Though the study favors levofloxacin, its effect on systemic disease needs to be evaluated. These are my references. Thank you.
Okay. So, what about the systemic disease? Because you have replaced a drug, so the ophthalmic you feel became much better. What about the systemic disease?
We are following up the patients, ma'am. They are doing well till now, but a larger sample size and prolonged period of systemic evaluation. If you have seen, my follow-up period is pretty much less.
Right.
At that
So
point in time,
further
the
study
patients
will
are still being followed up.
confirm the systemic is also getting better
Yeah.
with the
They
second line drug.
They are doing well till now.
All right.
See, I'm all for new things, but the essential issue here is that you are using a second line drug as a first line drug, and you are using it in ocular tuberculosis, which predominantly is a paucivacillary disease.
True, sir. And moreover, I am doing it in a TB prevalent society where ethambutol is the drug which is proven to say that TB conversion rates are better. I'm telling you, I'm using it only in ocular TB, not in pulmonary TB cases. Predominantly ocular TB, and the patients are being followed up with a pulmonary chest physician also, who is prescribing the drug. He is taking care of it systemically. He is following up the patient systemically. I am concerned about the ocular disease, where I have seen the risk of patients and having color vision, contrast problems, and developing optic neuritis have diminished.
All right. So we get it, because any eye disease we don't like to give ethambutol. It's okay. Thank you.
Thank you.
So we call upon our next speaker, Dr. Aditya Patil, single center experience of the impact of COVID-19 pandemic on 101 patients with uveitis on IMT.
Good afternoon, everyone. So I'll be presenting the single center experience of the impact of COVID-19 pandemic on 101 patients with uveitis on immunomodulatory therapy. So I invite you all to go back to the COVID pandemic period. We all know that the management of non-infectious uveitis patients was particularly difficult due to several reasons like risk of viral infection, severe disease, and immune dysregulation in these patients, and also because of the movement restrictions due to lockdown. So we designed a study to evaluate the patient profile, the episodes of uveitis, the modifications in treatment, the effect of COVID-19 disease, the lockdown and vaccination on 101 patients with non-infectious uveitis during this period. So this was a single center hospital-based retrospective study, and we had 101 patients. So we only took those patients who had non-infectious uveitis and who were started on IMT before or during the pandemic. We excluded those patients with infectious uveitis or those who were not on IMT. So we can see 101 patients were recruited from 24th March 2020 to 31st December 2020. You can see that this was mostly during the first wave, and we followed them up longitudinally all the way up to 31st Jan 2023, and which was in the vaccine era as well. So I'll skip this. Let's go to the results. So we had 178 eyes of 101 patients, and most of them were females, and most of them had bilateral uveitis. We had all kinds of uveitis. Most common was pan-uveitis, followed by anterior uveitis, and the etiology was also diverse. Most commonly, it was idiopathic, followed by sarcoidosis. So when the pandemic struck, 97% of our patients were lost to follow-up. And at the pre-pandemic last visit, 19% of them had active inflammation. But when they presented to us during the pandemic, because of the lockdowns and the prevalent situation, 32% of them had active uveitis. So their inability to follow up was associated with increased risk of recurrence, and this was statistically significant. When we looked at their compliance with the treatment, about 18% of them had stopped IMT. And of these patients, 89% of them developed an inflammatory relapse. So most of them had actually stopped their IMT on their own, and some of them had stopped it due to supply disruption. Then we looked into patients who had continued their IMT during the pandemic. So only 32% of them developed an inflammatory recurrence. So this was statistically significant, and this goes to show that maintaining immunomodulatory therapy during the pandemic helped to prevent inflammatory recurrences. These were the treatment characteristics, and let's look at the details of uveitis relapses. Only 44% of the patients developed relapses during the period. Most of them had 1 or 2 episodes, but in those patients who had 3 or 4 episodes, we saw that 5 out of 8 of those patients were not compliant with their IMT. Then let's look at the treatment modification details during this period. Majority of the patients required alteration in immunomodulatory therapy, and only a minority had adverse events from them. So the purpose is because we were worried whether these non-infectious uveitis patients, when the pandemic was there, they were at risk of contracting severe disease because of the virus, and we did not know the behavior of the virus. So majority of them required alteration, but only minority had adverse events from the immunomodulatory therapy. Let's look at the vaccine era. 6 eyes of 4 patients developed adverse events. So in general, vaccination was safe in these patients. These are the images. The case 1 had a VZV sclerouveitis, and another patient had HZO. And so out of 101 patients that we had in our study, 10 had COVID and 2 had severe COVID. 1 lost his life. Let's look at the details. We can see that 4 patients had continued their IMT and had mild disease, of which 1 patient developed severe disease. Later on, she developed comorbidities secondary to COVID, and 1 patient became critical with COVID, and he had stopped his immunomodulatory therapy. So in our experience, patients who continued the IMT in COVID did not have severe systemic and or ocular manifestations. So we know that in critical illness, when you have a critical illness due to COVID, inflammation plays a much greater role than viral replication. So maintaining IMT was beneficial. And we can see this is the morbidity details in our study. 1 lady, she became oxygen dependent, but she survived the severe COVID because she was on IMT. Another patient who was lost to follow because of the lockdown developed CNVM and lost vision. Another patient lost vision due to glaucoma. And when we compared our studies to other studies, ours was the only study with real-world data with a longitudinal follow-up, and we studied episodes of uveitis, the modifications in treatment, and the effect of the disease, the lockdown, and its vaccination. So in conclusion, I'd like to say that inability to follow up due to lockdowns was associated with increased risk of recurrence. Maintaining IMT in the pandemic helped to prevent inflammatory recurrences. Vaccination was generally safe in non-infectious uveitis patients, only a minority having adverse events. And continuing IMT prevented severe inflammatory manifestations of the COVID disease and reduced ocular and systemic morbidity. I'd like to acknowledge our team members. Thank you so much.
Okay, I think study because only 10 patients had COVID in your 101 patients, and out of this 10, 4 could not make it and 6 could make it.
Only one lost
One
his
died,
life. Yeah.
but 4 had COVID and others didn't
Yes,
have.
of-
So it's an almost equal data.
Yes, ma'am.
So it's a little difficult to say whether it was hanging. There were so many compounding factors. Anyway, it's a good study. Thank you.
ma'am.
So I think the next presenter is Dr. Nida Khan. Yeah. Her talk is on long-term ocular complications of BKH disease, a study at a tertiary eye care center.
This is not mine.
Next is Dr. Shivang. Dr. Diti, you were not present in the beginning, but you can speak after. CSR.
Good afternoon, everyone. Yeah. So the topic is out of one into another. So this is a case presentation. This is a case where we are also having a lot of diagnostic dilemma. So it's an open-ended case where people can pitch in. So there is a 35-year-old male, and his complaints was floaters in the right eye for a week and blurred vision in the right eye for a week. And there was a history of typhoid fever 3 weeks back. And the patient had a history of CSR much before this a year ago, and for which he was under treatment at that time, topical and oral medications, no laser or anything. And now coming to the presentation, you can see that there is a retinitis patch along the infratemporal arcade with hemorrhage and edema. And there was a ERM at the macula, and there was some RP degeneration. This was the OCT going through the lesion, which is showing a diffuse there was actually no total loss of anatomy, which is destructive anatomy at that area. And the other eye you can see has also CSR, like a fluid parafoveal and coming subfoveally with a small PED. And this was the FFA of the patient, and you can see that there is no a typical early hypo, late hyper in a case of a classic retinitis. There is just a diffuse staining of that in the very late phase. And in the other eye also there are multiple window defects, which is suggestive of sick RP, but there is no focal leak or there is no this thing which is suggestive of fresh CSR. So there are two options now. There is either and in the OCT also we couldn't find any cells in the vitreous cavity or anything like that. So it could be either post-fever retinitis or a central CSR. But the treatment is totally different for both. For a post-fever retinitis, we would start the patient ideally on steroids, and for CSR, ideally we should avoid giving steroids. So there was a management dilemma, but because the patient was having a history of typhoid, so we went along with the diagnosis of post-fever retinitis. This was the day macular OCT on the day of presentation. You can see a parafoveal SRF packet. We started the patient on cotrimoxazole and omnocartil 60 milligram and a weekly tapering dose. And you can see 2 weeks post-steroid, there was an increase in the SRF at the macula, and there was a huge SRF in the left eye also. So this is now becoming into a CSR which is decompensating because of oral steroids. So then now we thought, okay, let us quickly taper the steroids and continue on the oral antibiotics. And there was also the second thing was we started the patient on eplerenone. We did not do any hormone serum cortisol levels, but we just started the patient on tablet eplerenone. And post 4 weeks of eplerenone, you can see now that the SRF in both eyes have started resolving. And the retinitis patch also, you can see that there is a reduction in the hemorrhage and surface vascular hemorrhage and the SRF, and there was a surface vascularization around 6 weeks after the initial presentation. Till now, at any point of time, there was no vitritis or anything like that for the patient. So this is post 8 weeks, and you can see that almost all the SRF has resolved after continuous eplerenone to 50 milligram dosage. And the inferior retinitis patch has also become almost near inactive. But although in a typical retinitis there will be pigmentation as the lesion starts healing, which is not there in this case. There is just a white patch which is still there with some amount of surface vascularization. So the questions we have are, how could we have managed this differently? Should we have just started Septran TM without the oral steroids? Could we have managed the CSR differently? Because we did again an FFA, but there was no leak, so we couldn't do any focal laser. Was the eplerenone that acted in our case, or was that the natural course of steroid reduction which reduces CSR? Was it even a retinitis in the first place, because there was no vitritis, and although there is a surface hemorrhage and it reduced, we still are not sure whether it was retinitis, because it's such a localized patch in only one eye. And now that CSR is resolved, how frequently should we follow up this patient? These are some of the questions we are posing, and that's it. Thank you.
So it is a problematic case presented,
Yeah.
which needs to be answered by the
Just go back the slides
even
to the point where you added
eplerenone.
Eplerenone.
yeah,
There you
and
have
the slide
steroids.
before that.
Yes.
You have steroids as well as eplerenone. Just go back.
Yeah,
to
yeah,
the
yes,
slide.
yes,
So I
yes.
was wondering why.
Yeah,
It is
so
skipping
this
it.
was the,
Iske pehle
okay,
wala.
no, okay, this is the time I started on
This is
eplerenone.
where you started.
The post 2 weeks, the patient presented in the second one, this is how he decompensated. And at this point, I started eplerenone.
Go one slide back.
This was the presentation.
And then go to the next slide.
This is the same slide I've put in the same thing, up and down.
So, is the hemorrhage reducing there?
Yes, sir, the hemorrhage is
And
reducing.
is the
there.
retinitis
Yes,
patch getting
yeah,
localized?
it
This is
is
before you added.
added
the-
eplerenone. Yes,
Yeah.
sir. Yes, sir. Yes, sir.
And just the next slide to this.
Yeah. And this is 4 weeks later. The hemorrhages have almost totally regressed. There was some small fibrillary surface vasculature which was there. I can zoom in. Yeah, you can see there is a minimal surface vascularization at that point, which was not there previously. And I don't know whether it's a classic CSR or not, but I mean classic retinitis or not, but it is a weird case because there was no vitritis also at any point of time.
So it could be a self-healing also, according
Yeah,
to me.
yeah, could be.
All right.
Okay.
Any comments
Yes,
from
ma'am.
Dr. Manisha?
Yes, ma'am.
Yeah.
Steroids. Right. It's the first slide as it.
No, but that's through the macula, na? Not
Through,
through
no,
the
no, no.
cancer.
First, through the macula at the first
No,
visit.
no, no.
The lesion is there, ma'am. I mean, can you
It's
just
a
put it
little
up?
far away. I think you couldn't take the.
No, no.
visit.
I have taken only the first visit we could take. After that, we did not take it. This was the one, ma'am. Through the lesion, ma'am. This is through the lesion, is what it is. Excuse me. एक और बार लगा. This one, ma'am. This is through the lesion. Yes, ma'am. Yes, ma'am. There is a PED also. Decompensation. Yes, ma'am. Yes, ma'am. Okay. Right, right. Right. Right, right. Okay, ma'am. Point taken.
So to say these are, these are two separate entities.
Yeah.
I mean, you had a post-fever retinitis,
Yes, ma'am.
which you treated.
Yeah.
You caused a side effect.
effect,
Then you
we
treated the
treat
side
that
effect,
also.
which you could have just observed.
So good. It's a nice case.
Thank you. Thank you.
It's rather a learning case. Huh?
Yes. So sometimes observation is the best. So I think Dr. Nida Khan is ready. So she will be presenting on long-term ocular complications of Koyanagi-Harada disease, a study at a tertiary eye care center.
Good afternoon, everyone. Today I will be presenting on long-term ocular complications of VKH disease. VKH is an autoimmune granulomatous disorder which involves T-cell mediated autoimmune dysregulation targeting melanocyte self-antigens. It's lead to vision and hearing disturbances, Ocular manifestation is characterized by bilateral granulomatous uveitis associated with serous retinal detachment. Till date, very few studies have evaluated long-term complications in VKH. A study evaluated ocular and extraocular complication with a follow-up duration of more than 6 months of the initial diagnosis of VKH disease. Another study evaluated ocular complication at the time of presentation. However, the purpose of this study was to evaluate the spectrum of long-term ocular complication in VKH patient observed after a follow-up period of more than 3 years at a tertiary referral center. This was a retrospective observational study conducted between 2015 to 2020. Analysis of electronic medical records of newly presented VKH disease patients with a follow-up duration of more than 3 years was done at a referral clinic. The study included 122 eyes of 61 patients with 16 males and 45 females. The mean age at diagnosis of disease was 36 years. The mean duration of uveitis from the onset of symptoms was 6 months. The most common immunosuppressive drug given to these patients was azathioprine, followed by mycophenolate, and then a combination of azathioprine and cyclosporine. Most common ocular complication which we encountered was cataract, followed by ERM, glaucoma, posterior synecdoche, retinal detachment, CME, subretinal fibrosis, CNVM. The most common extraocular manifestation was meningism in this patient, followed by hearing loss, vitiligo, tinnitus, alopecia, and poliosis. Most common complication with steroids was glucose intolerance, followed by hypertension, osteoporosis. One of the patients developed avascular necrosis of femur head. Most common complication with a steroid-sparing agent was bone marrow suppression, followed by hepatotoxicity. One patient developed tuberculosis, another developed oropharyngeal candidiasis, one patient developed reactivation of herpes zoster, and another developed GI infection. 39 eyes required required cataract surgery. Vitreoretinal surgery was required in 5 eyes and TRAB in 3 eyes. Intravitreal anti-VEGF had to be given in 10 eyes for CNVM, and 7 eyes required intravitreal steroids. Post-treatment, the visual acuity improved in 61 eyes. It remained same in 33 eyes, and it worsened in 28 eyes. VKH is usually diagnosed at the age of 20 to 50 years. It is frequent in pigmented races, and females have a slight predilection. In the present study, the mean age of diagnosis was 36 years with 16 males and 45 females. In the present study, majority of the eyes, that is 94.3% of eyes, developed some ocular complication after a follow-up period of 3 years. It is consistent with the finding involving 18 VKH patients, in which 83% of the eyes developed some ocular complication. Cataract was the most common ocular complication encountered in our study. It is comparable to a report of 101 VKH patients that showed cataract being the most common ocular complication in VKH patient. There is a photograph of one of our patients of VKH disease showing circumciliary congestion, granulomatous capes, iris nodules, and complicated cataract. Meningism was the most common extraocular symptoms, followed by hearing loss, vitiligo, tinnitus in our study. It is comparable to the findings of Monkar et al. On Indian patient, in which meningism was the commonest extraocular findings, followed by auditory disturbances. In our study, all patients required immunosuppressive therapy. Azathioprine was the most commonly used one. However, only 39% and 16% cases required steroid-sparing agent in a study by Monkar et al. And Potapoval et al. Respectively. This is the OCT image showing bacillary layer detachment and urothelial detachment before and after treatment. All of this was resolved. Surgical intervention was required in 39% of the eyes in our study. This could be due to the long duration of follow-up of 73 months in our study, that majority of the patients acquired some ocular complication which was the need for surgical intervention. However, in a study with a duration of 15 weeks of follow-up, only 7.6% require some surgical intervention. Following treatment, the vision improved in 61 eyes, remains in 33 eyes, and it worsened in 28 eyes. The worsening of visual acuity can be attributed to various ocular complications. This is the ICG image of one of our patients showing reduction in number of hypofluorescent dark dots after treatment. To conclude, majority of the eyes develop some ocular complication after a follow-up period of 3 years. Dose-limiting complication developed in 34% and 26% patients with IMT and steroids respectively. Early diagnosis and prompt treatment of VKH with steroids and IMT can preserve vision and delay development of complications. Dose-limiting complications of steroids and IMT can be averted by timely adjustment of dose and replacement with other agents as required. Thank you.
See, it's a nice paper. It's just a comment that I'm making. I just thought of it while you were presenting. The Monkar et al. Paper that you are quoting here is a 2000 paper.
Yeah.
Yeah, and it's from your institute only.
Yeah.
So you are saying only 39% required immunomodulation. I think back then we weren't
sir,
probably using immunomodulation so much.
Hmm.
What I'm trying to say, it may make sense that you compare this data with the data which was used for that study and see if outcomes are now better with more with better use of immunomodulators. I think that
Yes,
that
got
would be a very pertinent thing. Another just very random thought that came to my mind, and there are other uveitis specialists here, so I would like to know their opinions. One patient has developed avascular necrosis of fever of the femur. How many of us here are using bisphosphonates weekly in these patients in whom we are using steroids? Because our neurology counterparts, because I work even as a neuro-ophthalmologist, they use weekly bisphosphonate as soon as they put the patient on even 60 milligrams of Wispan. So I think that would be a good idea, because we tend to use steroids longer than they use. Because yeah, so as soon as they write 60 milligram Visolon, they will write Osteophos 70. And they use it, and I talk to them, and they are as if it has to be used. It cannot not be used. I mean, so for quite some time now, I'm thinking that that should become a part of even our regimens. Because AVN is a devastating complication for them. It's just that one fine day they will have something and something will happen. Yeah.
Similarly, they were talking about the HBS status
Yeah. Yeah, yeah,
for
yeah.
I think the protocol division will also have to look at adding bisphosphonates there.
Yes.
Like as you said.
Yes.
I mean, I'm just telling the protocol needs to be revised.
Yes. Yes. Yes.
So nice discussion. So we go on
Yeah.
with the next
Thank you.
next candidate. Clarity in and about pediatric uveitic cataract surgery, etiology and outcome. Dr. Shivagami.
This is the last one, no?
A very good afternoon to one and all present here. I'm here to present about clarity in and about pediatric uveitic cataract, etiology and outcome. Though the prevalence of uveitic cataract is very rare, about 70% of the pediatric patients develop uveitis-related cataract over time. However, the output of the cataract surgery depends upon a lot of factors. So hence we did a retrospective analysis to evaluate the etiology and outcome of cataract surgery in children with uveitis. Coming to the materials and methods, it was a retrospective observational study conducted between January 2019 to 2023 in children less than or equal to 16 years with uveitic cataract, which was done at the Pediatric and Uvea Clinic of Arvindai Hospital, Pondicherry. We included children who were less than or equal to 16 years and who had uveitis and had undergone cataract surgery, and those who came for at least 12 months of regular follow-up. We had to exclude patients who were more than 17 years or those who underwent cataract surgery elsewhere. The data collected included the patient demographics, the etiology, the vision, intraocular pressure, anterior and posterior segment findings, the treatment, surgery, and the complications. Coming to the results, there was no disparity between the male and female children, and the mean age at diagnosis was 10.7 years, and the mean age at the time of cataract surgery was 14.1 years. Among the 14 eyes of the 12 patients, 4 had bilateral uveitis and 2 had bilateral cataract. On analyzing the visual acuity, compared to the preoperative visual acuity, there was an improvement in the postoperative visual acuity. But however, in the 6-month period, we saw there was a small decline in the visual acuity, which can be attributed to the posterior capsular opacification or the pigmentation of the intraocular lens. The mean intraocular pressure preoperatively was 13.6 millimeter mercury and postoperatively was 15.4 millimeter mercury. One patient had laser PI preoperatively for secondary angle closure, and one patient developed steroid-induced glaucoma at POD 15. On analyzing the etiology, majority of them had non-granulomatous uveitis with pan uveitis for 37% and anterior uveitis 27%. GIA accounted for 34% of the patients, followed by sarcoidosis in 25%. The mean duration of the oral steroids was 8.35 months, and preoperatively was 4.96 and postoperatively 3.39 months. Among the 2 eyes which underwent vitreoretinal surgery, the majority of the duration was given postoperatively. On analyzing the duration of the methotrexate which was given, it was given for a mean of 19.28 months, among which majority of it was post-operative. An inflammation-free period of at least 3 months was ensured, and cataract extraction with or without foldable hydrophobic acrylic lens was done. Additional procedures like intravitreal triamcinolone and posterior subtenon tricot were given to reduce the intraocular inflammation in some children. The other procedures, which included intravitreal Avastin, EDTA chelation, membranectomy, yak capsulotomy, were also done. All children underwent peripheral surgical iridectomy. The other post-operative complications were also analyzed, and the mean duration of onset of the cystoid macular edema was 2.5 months, and onset of posterior capsular opacification was 4 months. The levels of inflammation post-operatively showed a decreasing trend over the duration, but however, posterior synechiae and pigments in IOL had an increasing trend. Coming to the discussion, our study revealed that the post-operative visual outcome of most of the patients was satisfactory, and the systemic immunosuppression was needed to control inflammation, and dose augmentation was required in case of flare-ups in 3 cases. All eyes underwent primary implantation of IOL except one eye which required a staged secondary procedure. So some studies which were conducted in Israel and India suggested that cataract surgery improved vision in eyes regardless of the IOL implantation or not, but posterior capsular opacification leads to more secondary procedures in the pseudophakic eyes, just like ours. And a few studies retrospectively done also suggested that immunosuppressive treatment with biologicals can improve the visual outcome in uveitis, but it does not significantly reduce the post-operative ocular complications. So we would like to recommend that systemic immunosuppression in the form of steroids and antimetabolites should be given to decrease inflammation. And it's crucial to identify complications and refer them for timely management to prevent amblyopia, and regular and long-term post-operative follow-up with systemic monitoring is essential. These are my further references. Thank you.
Thank you. So that brings us to the end of the session. Any speaker who has come later? If we have finished with this session, thank you.